Morning, this is the House Appropriations Committee. It is Thursday, February 26th, 2026, 2/26/26. Okay, it's 9:30 and we are starting to take testimony on letters from our policy committees. And our first one is this morning, and we're delighted to welcome Chair Black and Vice Chair.
Ranking member
Senator Rebecca. So welcome. We're looking forward to hearing about your letter. And if you want to introduce yourselves and tell us all about it.
Thank you, Madam Chair, for having us. I'm Representative Alyssa Black, Chair of House Healthcare. And
Ranking Member Rebecca. Well,
so I thought I would just start with an overview of how House Healthcare develops their budget recommendations. We first invite in all the various agencies, departments that House Healthcare has purview over, which is essentially DEVA. We do hear VDH, although Human Services also hears from VDH, DMH, and the central office at AHS. We do not typically hear from Dale. So just wanted to put that out there. They essentially come in and they give us the same budget presentation that they have already given to you in House Appropriations. And at that point, once we've heard from all of them, if there are additional questions, we meet sort of offline with them to get answers, our budget liaisons. And this year, our budget liaisons were Representative Houghton and Representative Rebecca. We try to answer all the committee's questions on the governor's budget recommends. And at that point, we also start having in all the various agencies or organizations that are either subject to cuts or ups or downs within the governor's recommend, as well as additional organizations who may or may not have received any mention at all, and whatever their asks are. Then we go through a process within our committee where we spend essentially a day going over the whole entire spreadsheet, which you have, I believe, in front of you. We organize on a spreadsheet all the asks that we've received. We go through, we make sure that everybody in the committee understands all of them. And then we go through what I have described as a laborious process of each and every member within our committee ranks their top 5 recommendations in order of what their recommendations are. And then our JFO, Nolan, sits over at the table and calculates the total number of points that every single ask has gotten. And that is what you have in front of you, which is our priorities 1 through 10.
so the other spreadsheet you waved around, we do not have a copy of that. I don't know whether we need one, but if you'd like us to have one, that might be helpful, but I don't believe we got that.
I believe that was sent with our letter. We did send
We
that.
check and see. Okay. We'll let you know if we need to get
Yeah,
it.
I believe that our recommendations to appropriations were our letter, which included our top 10, but not the entire spreadsheet,
Right.
as well as additional language that we are suggesting for the budget.
Okay, yeah, and then post it. That'd be great. Okay, so so we have your 4-page thing that includes language and your top 10.
Yes.
We will get the spreadsheet as well.
I just want to appreciate the very, very difficult job that you all have in this committee. And as I reminded our committee, we are a policy committee, and we made our recommendations based upon what we feel are the top priorities on policy. We did not take into account the money piece. And so I just want to make sure that put it out there that you have a very difficult job to do. But if you are going to take any of our recommendations, we want to ensure that you have what our top priorities are. And if it's able to be found in the budget, then that we hope that that would be achievable. So coming in at number one, and I feel like every year the VNAs come in every year at number one. And I want to make it very clear because in last year's budget, they also were our top priority. And the VNAs can be separated into two different categories. There is the home health portion, which is if you think about you're hospitalized, perhaps you have a wound that needs dressing, or you need nursing care in your home. And a nurse comes out and provides clinical nursing care. That is the part of the budget of VNAs that we have. And we are recommending a 3.5% increase in their rate for this home health portion of it. VNAs also provide care in the home, and they provide care for like assistance with daily living type things. That is usually in the purview of the Human Services Committee. And last year, a rate increase was put in the budget for those types of services, but home health of VNA was left out. So I wanted to make that point this year. Again, they are, and they have also been receiving cuts from Medicare on a federal level.
1.8 million or something?
Yes. Every year they've been receiving a lower, and their rates have been decreasing from Medicare. And I'm not sure if the VNAs are in here, but they've also some clawbacks.
Yes. So when you see VNAs, so we have an Addison County Home Health and a Hospice. Is that considered a VNA?
That's a VNA.
Because I
Yeah,
don't think of them the same.
the VNAs are almost like in a small way, they're almost like how our system of designated agencies
Okay.
and
So that's sort
FSAs.
of catch-all name for all of those
Yes.
organizations.
Um,
I just want to be sure we're not leaving some out.
and every single health service area is covered by a different VNA.
Take a look at that as well here. How many of those?
Oh my goodness, what is it, the 8 or 9
You're not-
VNAs? Is it 8? Yeah,
Eight.
thank you. I can't believe I recalled that.
So there's 8 across the state?
Yes,
So it's out.
Yeah, okay.
there's there's 8, and then there's one private one. There's a private one also, I believe.
We've heard the number 3.5% increase across the board. Some of them are for the same things, but it's all about these services in different places. Does that represent an increase in overall funding, or is it for salaries or I'm getting the feeling that salaries or reimbursements, I don't know how it's phrased in your world where, if a service provider is given, $20 to show up, is this going to be $25 now or whatever the number is? Not that much, but.
Yeah, it would be the Medicaid rate for that particular service. So a VNA would bill, and I think it's often a case rate on the number of weeks. But it's also individual services, like nurse went out to that house and was there for 15 minutes. There would be a code that would be billed. Medicaid would pay their reimbursement that they have as their allowed amount. And this would be increasing that allowed amount 3.5%.
So and which matches inflation, I think. Roughly.
Yes.
And so the age old canard in funding, which is if you give me $100 last year and $100 this year, you're really giving me $96.
Yeah.
And that's the spiral down. And so this has been what Human Services has been talking about for years.
Yes.
Yeah.
So
And I believe this rate has not been raised in a couple of years.
it's almost truing it back up to what it's.
Well, I'm not even sure it's truing it back. What they're trying to get is to the equivalent Medicare reimbursement. And they're trying to get to 70%. Right now, I think they're around 60. And
Percent of Medicare.
yeah, of Medicare. So imagine Medicare already has a relatively low rate. Medicaid pays less than 70% of what Medicare would even pay for that service.
This would bring them up to 70%.
Yeah, this would bring them up to 70.
Okay, so Marty,
So you indicate that this is distinguished from what we also call home health services.
Yes.
or Assisting with either meals or making or things like that.
Yes.
So do we need to be very specific in
It's a
terms
skilled
of
nursing.
codes?
No,
Be great.
no, this is
yes, we have some other issues about that, I think. So Noel, state director payments.
For the record, all that would go, this would go under section 307, and it would go under code for skilled nursing, pediatric palliative care, and high-tech nursing.
So we have a way of distinguishing what you're looking for from the other.
Right.
Okay.
Okay. And then, so the Medicaid rate is set by the federal government.
the Medicare rate.
Medicare,
But Medicaid rate is set by
the state,
the state.
that was where I was getting to. Thank you.
Devo would set that rate. So our second ask is Vermont free and referral clinics. I think that one of the things that I know I personally approached with budget recommendations, and I know many other committee members, is because we are in such a tight fiscal year. I sort of prioritize agencies or services that really have no other way of supporting themselves and how vital they are. Our free and referral clinics right now, and I want to remind everybody, these are clinics where the providers within these clinics are all volunteer. These are volunteer providers. What they
Doctors
do,
and
the
nurses.
doctors and nurses, what they do need to pay for is they need to pay for the facilities that they're within. They need to pay for the staff who staffs them, as far as, the person who's sitting at the front desk when you come into the clinic. Cleaning staff, just any kind of upgrades to the facility. Supplies. They are frankly overwhelmed, and they're overwhelmed with the need as insurance becomes less affordable. People are going without, or their out of pocket is so, and they charge nothing. Free and referral clinics charge nothing for their services.
Anybody can go to them.
Anybody can go to them. Anybody can go to them. And frankly, they're a little overwhelmed with the need. And many of them would like to increase the hours that they're open. I think we heard from the free and referral clinic that, look, there he is. In Barry, you're open currently 4 days a week?
3.5.
3.5. And would like to expand to more days because the need is so great.
So this is one place that's taking the place of people who dropped their health care because the premium tax credits went away and they
Yes.
can afford $2,000 or $3,000 a month.
Yes.
And instead of going to the emergency room, which is the most expensive place to go, and I assume some are still going there, they can come to the free and referral clinic.
Yes.
Okay, and do
They
we
provide
know?
dental care as well, which is
Okay.
very, very important.
Yes, and do we know at this point how many people didn't re-up for health insurance?
Oh, let's see. I'm sorry, we heard from, 2,500? 2,500. And they're recalculating each month because each month people are dropping off as they realize that they cannot sustain the premium. So
One
go ahead.
number we heard from the free and referral clinics is that their patient load increased by 40% last year. Yeah, it's significant. 2025.
Calendar year?
Yep.
Yes.
And the insurance, right, so even without the insurance drop, yeah, they're
But we had
increasing.
double-digit rates.
That's right, the insurance rates the previous year went up a whole lot too. So they probably lost a few then, and then we're losing more with the second round of healthcare cuts and costs.
So our third I'm sorry, were there any other questions on?
I think we're good on, oh, wait, sorry.
You mentioned clawback. What's the magnitude and what was the cost of these clawbacks and how does that affect its operation?
The clawbacks are coming from CMS, the federal clawbacks, and I have to be honest with you, I am not really well versed. There was some rule that came down many years ago federally, claiming that home health had been overpaid. I think it had something to do with budget neutrality on and so over the years, they've been, first of all, cutting the rate each year and threatening clawbacks of money that was paid many, many years ago.
But not for a specific thing that was done.
Not for a
It's
specific
just
thing,
like-
it's just,
State, national.
it's like 10 years ago, we think we paid you too much because of budget neutrality, so therefore, we're gonna take it back.
It's not just us.
And it's been threatened, I know, for many years, and I believe that they might have indicated that the process might begin this next year.
Is that clawback in full or was it a portion of?
It's a portion
Portion.
of some determined CMS calculation.
So there isn't anything we could do to prevent.
No.
There's nothing that was
Nothing.
wrong that was gonna.
And there's nothing we did wrong.
Right.
But what's the magnitude of the hole that's put into?
I'm sorry, I'm really not sure about that.
At least 1.8 million less than what they had. And that happened the previous year too.
Those 1.8 million?
Yeah.
So
On to number 3.
number 3, SASH, and can I make an assumption that everyone in this committee?
Might remind us what SASH is.
SASH is an organization that provides sort of wraparound services to seniors living in sort of senior communities. And like Cathedral Square it's funded through Cathedral Square, and they have SASH services, I know, in Chittenden County, and also they serve 5,000 low-income seniors across the state. SASH is a nationally recognized team-based program of care coordination shown to improve population health, and it saves on Medicare dollars and helps people stay healthy so that they can remain living at home rather than going into.
And you said, no.
Yeah, they've been growing for the last 10 years. Started off with pilot programs, we added it as part of our budgets. They work as pods.
Mhm.
Each pod is about 100 people, and the success rate of keeping people in their homes healthy. It's always people checking on them. It's been a huge success in both Cathedral Squares and in what I know of in Washington County. In terms, I'm surprised that they weren't funded. It's been or they've been cut, whatever the mechanism is here from the administration, but they've been incredibly successful.
And it's less expensive to keep people at home than put them into a nursing home or into the hospital.
It works
And
against
that's the
some of
theory.
yes, it works against some of the nursing home issues that we're dealing with. Except
Right.
that it's just much less expensive. It's less chaotic for the people who are being served, because leaving home to go to a nursing home or to a hospital is worse for your health, just leaving home.
Yes.
But it also integrates with Meals on Wheels, and there's just a whole bunch of services that are provided right there at home.
Marty?
Well, do these beneficiaries, are they only in organized groups like Cathedral Square, or does this SACS provide services?
You know, I think
Random person down in the neighborhood?
Brattleboro, I believe in Brattleboro, they've actually extended it to sort of families. But, you know, their current model and the pilot was essentially in sort of senior living communal type settings.
Like a retirement community?
No, not necessarily, well, and for instance, in Burlington, there's Decker Towers, which is,
It's a low income.
it's a low income,
It's for district.
yes,
Public housing authority.
yes. So this funding is essentially bridge funding. They were funded previously through the all-payer model, and this is bridge funding to get them through to the AHEAD model.
And that's what we had to do last year.
Yes.
We thought the ahead model was gonna happen, starting this year, and it didn't.
And it didn't. So this is another
We
year.
did fund it last year for that reason. But so, Mike had a question and then to,
No, I just wanted to share how there are different models around the state. Brattleboro, the Brattleboro Housing Authority, they have teams that will actually go to individual homes to see what people need, first of all, make the home safer. That's what service they need, so it's not just
Not just in an organization.
trying to get to them.
yeah.
Going out to the community. And I don't know if Brattleboro is a pilot program for that. But I think around the state, there are different manifestations about.
However it works around. Is it statewide?
It is not statewide, but it is expanding into new communities although this is not an expansion at all. This is to maintain where they are.
Okay.
Yeah, I think we didn't appropriate enough money last year,
Right.
to expand it. The ahead model, just in a nutshell, where are we with that? And is that truly gonna come to be? Or is that really in,
I believe that they still think that it's going to come to be. It has, AHS, Agency of Human Services. I think the model has changed a little bit on the federal level. So what we thought the model would be, I believe, has changed a little bit, but we're still waiting for, I believe we're still waiting for guidance from CMMI or CMS, the federal, that's on what is going to be in the model. And I think it's still being designed. So last I asked was probably 2 months ago, and they're still waiting for guidance.
So SASH is a part of the Agency of Health, Human Services, or is it?
It's an independent, it's a nonprofit.
And it's called SASH?
Yes.
Dave, did you have a question about it?
Services.
No, I was trying to recall what seniors and supported housing, sometimes.
Support and services.
It's support and
Thank you,
services at home.
Lynn?
Yeah, it may be independent and maybe a nonprofit, but the money has to flow through somewhere. Where does it flow through?
Well, it was flowing through the all-payer model.
So that is what, Department of Health?
The all-payer model is all insurers paying it.
So that's no longer around.
That's no longer around, and this is the bridge funding that used to come from. And I believe it was paid through the blueprint. But it was paid through the blueprint, but it was all payers, Medicare, Medicaid, and then I think that SASH was just Medicare and Medicaid. And this is for the Medicare portion, because Medicare is no longer paying into that.
Okay, so does that come through DIVA?
It will go through DIVA? Yes.
I think so.
And I think, was this the one where hospitals paid a little bit and the health insurers paid a little bit through the ACO, and that's how it ended up getting funded?
I'm not sure
That's the alternative.
that I mean, yes, they paid into the all-payer model, but I'm not sure that the funding for SASH in particular came from that. I think it might have just been Medicare and Medicaid
Okay.
in a big pot.
Yeah. And then, how long has the program been around?
Why do I not have Representative Houghton with me? Madam Chair, she is the expert on SASH. I think it's 8 years.
More than that, it started out as a very small pilot, I believe, in 97.
Oh,
I
wow.
was there,
So 20 years.
long time, but it's grown since then,
Yes.
so.
2011,
2011?
Yeah.
14,000 participants since 2011,
before.
200 plus housing sites, and it was funded federally, primarily federally until the ACO went away,
Yes.
and we needed this bridge funding.
Okay. So 15 years more recently, so maybe pilot back when in Dave's time, but 15 years for the kind of the program that we're seeing now.
Yes.
Okay, yeah.
And it is, I would consider it a mature program.
Yeah.
You know, and it went through the process of being a pilot program. It went through all these different funding sources to get to the point to try to get into the budget and with all the help that it receives. SAF for Families is an extension of that program. It's specifically because this worked so well with seniors that they brought it out and they're piloting it in certain counties where it's going. So children are receiving the services in ways that are the same as seniors, and it's just children or families with children. And it's just a remarkably successful program for the people it's serving.
Okay, so that was Mark. Go ahead.
On all of these first three, you indicate that there's a state amount and it appears that there's a federal amount because you have another gross amount. So are you certain that there's federal funding available to match this state money you're asking?
Records
yes.
all day, all day. We can match the global commitment.
Global commitment, they can match it.
We're backfilling the Medicare portion. We already have a Medicaid portion, so we'll continue to do it with global commitment.
Doesn't that imply we're getting the federal funds for the global commitment?
Yeah, but so you have Medicaid in the state and federal partnership, and then Medicare is pure federal. We're losing the Medicare, so we're just increasing our Medicaid share to offset the loss of Medicare. Because of that, we can continue to use our global commitment match, so we can get federal match of that, so.
Okay, I think I have Lynn and then John.
Yeah, thank you. Did you hear anything from the Green Mountain Care Board about any of these things that are on this list, in terms of what they're expecting in terms of how this all works together financially from their perspective, when you're talking about we've lost the ACO. The ACO may be if AHEAD moves ahead, it may in fact send the money to an ACO instead of to the state, which I think we would prefer goes to the state, from what I understand and talking to them. Did you hear anything from them?
We heard nothing from the Green Mountain Care Board on these budget items, particularly as it pertained to AHEAD. I think that they are waiting to see what happens with AHEAD, just like the rest of us are.
And did you hear anything from the Rural Health Transformation Group?
Well, yes. So there's a couple items on here, and SASH was one of them in particular. I'm looking for, so the rural health transformation, there were several cuts within the governor's recommend, or I should say, not even cuts, but more didn't get a mention, where we heard, we think we can use rural health transformation. And as there was more questioning, it became very, very confusing on whether or not any of these things would actually be eligible. SASH was one of them. I think that there's still a little bit of confusion over whether money can be used in Chittenden County. I think we heard from AHS at the presentation that they did in front of the Joint Fiscal Committee. Just that the money has to, so it's for rural, and the rural designations within the rural health transformation does not include Chittenden County, and that the money actually has to flow. It flows to where the person is when they're receiving the services. So there was a lot of confusion over SASH in whether or not the rural health transformation money could be used for that because it's not primarily, but there's a large portion of it that's in Chittenden County. And if I see joint fiscal over here and probably going to correct me and everything.
No, we also had the Washington delegation in to talk to us, and we brought this up.
Yes.
So, but I would have Nolan and then,
It's not going to correct you, I'm gonna help, provide some additional information.
Yes, please.
So the AHS has submitted their budget to CMS, which has been approved, and there's nothing for SASH in that approved budget. There's nothing in the RHTP currently proposed around SASH, there's from relative blueprint, but not that.
okay, thank you for clarifying.
And the RHTP funds cannot pay for direct services as well.
There's a lot of, so we're gonna have Jill Mazza Olson in here on March 10th, I think, when we get back. And we're gonna go through that whole grant program and all, I mean, the 38 projects. And we know it keeps changing.
I would can I add one thing about SASH? Because this has come up in our committee the last couple of years as a priority program. And I think it's because, and Rep. Dickinson, I think you're kind of getting at this in terms of looking at larger healthcare reform strategies, really, making sure things are aligned and we're investing in a vision. SASH is something that really keeps folks at home and brings the services to them and connects people to the services rather than having folks leaving their homes, needing transportation, needing all of these other things. SASH actually connects them to the services that are already existing. So it's a really critical piece of any healthcare reform thing that we do, allowing people to age in place. And I think our committee
Yes.
sees great value in that.
And in ensuring that people are receiving the right care at the right time in the right setting, as opposed to things becoming, an emergency and ending up in our hospitals.
That is also what keeps our costs low.
Yeah.
It's programs like SASH.
And, right, John, did you have a question too?
Well, questions I had have been answered, but when we had Jill Briggs come in and talk about some of the rural health transformation program, and some of that is.
Jill Olson.
Oh, Jill
Yeah.
Olson, excuse me. Wrong.
Not education.
Work for Jill. I just recall part of that program was to bring some services to people, but we don't know exactly what the specifics are to.
Right.
So some of that might be happening if something could be funded in full, I don't know.
I think it's sort of up in the air.
It's up in the air, yeah.
So if this doesn't get funded, what happens, SASH?
It ends.
It just ends.
It ends.
Okay.
Again, we sort of prioritize things where if it
Right.
doesn't receive the funds, they have no other mechanism for
Okay,
receiving
that's
funds.
fine.
And these programs just end.
Yeah, okay, thank you. Let's move on. We don't want to, we can probably have you here all day, but we don't.
Yes, which leads to, we have 10:30 testimony, which leads to, number 4, which was a tie. We have a tie. And I did not make everybody go through and do a tiebreaker. I'm sorry, I wasn't doing that.
That's fine.
So we have a tie, and there's really 2 pieces here, and this also kind of weighs in on the RHTP funding. So in the governor's recommend, there were cuts to AHEC and there were cuts to VSAC. And this is all specifically around workforce development in healthcare. And because within the RHTP, there are proposals around workforce development for health professions, those are mainly covered by the VSAC cuts that were made. Nothing that AHEC does would be replaced. This would be gone. So AHEC has no other, or what we heard was that there is no other, there's no ability to use the RHTP with AHEC, which is why it ranked so highly. These funds are used for physicians, They are loan repayments for dedicated service obligations for physicians and primary care specifically. They also have, I think it was 50,000 of this they use for a program which actually it's sort of a clearinghouse for open positions within Vermont, within primary care, and helping place primary care physicians in needed health centers around the entire state. And then there's also a piece where I have to be honest, I didn't really know this until this year, but I think it's fantastic. They have a program working with youth in Vermont and exposing them to health professions. And
So we knew there was that part. Lynn, you and I chatted about this at one point. Can you break out how much is for the youth programs versus how much is for loan repayment for primary care?
I am sorry, the spreadsheet that I have in front of me doesn't have that breakdown, but I know that we had that and we can get that for you.
That would be helpful to understand that because how tight things are and if we're making decisions and can partially fund things. And I'm not promising anything, but it'd be nice to get that level of detail.
Yes. And am I correct that they get a 50-50 match? Is that a 50-50 federal match, Nolan? Okay.
It's 50-50. Okay. Okay, Lynn?
Yeah, okay, they get $550,000 for this. 50,000 goes to the position of recruitment, which I understand is third-year medical students.
Or third-year residency?
Those third-year medical students, to recruit them to stay in Vermont. So look for their residencies here in Vermont. I believe.
Okay.
Now, the question on that is, does anybody have any data on the success rate of any of this, whether it's residents or medical students? Number two,
AHEC does have.
if they have data, or UVM has data on that, that would be helpful. The whole goal of all of these programs, from what I understand, out of the Department of Health and with VSAC, is to go and recruit and maintain and give the money to people who will actually work and stay in Vermont. And that's the number one goal.
Even after they complete their obligation,
Everything.
absolutely.
Yes. And so the second thing is that there is a thing for, I guess, high school students. That is the outreach, and I don't know if that's the full 500,000, but again, what exactly does that do? AHEC is generally used to go and help forgive loans for existing professions, nurses, doctors, dentists, whatever. Again, with the idea of trying to keep them here, they work here, they get a certain amount of money, and then hopefully they stay here.
They have to, it's a one-to-one, it's a
It's a one-to-one.
one-year
Yeah,
funding
come
if you
and-
stay for 1 year.
Yeah, to get whatever the money is, 10,000, 20,000, whatever it is, and then you work that year.
Yes.
And the problem is that sometimes they leave after that first year. I mean, that's one of the, but I'd like more data on all of that. I don't know if it's from UVM or if it's from.
We have that and we will absolutely get you that
Yeah, that would be
information.
Who would have AHEC in their budget? Is that Dave? Is that you or is that?
I
VDA.
thought it was Lynn.
It's Department of Health.
So it's you, okay.
But it sounds like we want.
Pass
through.
Right, so we want some more data on this. I'm gonna move us along because we have people coming in at 10:30 and I know we're gonna want to break. So if you have a burning question, ask it.
Just want to check, is this the same, forgive the loans for nurses and such, is this the same what we worked on with the economic development committee?
That's actually number 10. So VSAC, through VSAC, they do more nursing and other health professions. Radiology technicians,
Different programs.
different dental hygienists, yeah, allied health. Thank you, allied health professionals.
Allied health, yeah.
Really quickly moving on to Thai, I don't think that this really needs much explanation. Vermont Care Partners, which is all of our designated agencies and our SSAs.
Is that a 3.5% also?
That is I believe it's 3.5%, yes.
And I haven't been able to verify that, they're asking for 5.8 GF, whatever it is. They're saying it's on their calculations, 3.5%, but I haven't been able to verify that it's 3.5 or 3.2 or 2.8.
Okay,
We're staying away from the percentages.
Yes.
At this point. It's saying they want 5.8, whatever that grows up to.
Okay.
10 million, 11, 12 million, whatever.
okay. Right, we have to, yeah, I understand.
We all know the services that they provide and what the state of Vermont has tasked them with doing, and this is essentially a cost of living increase. So I don't think. So number 6 is a program through Howard Mental Health, and it is a community outreach where the proposal from DMH was that it could be supplanted with mobile crisis. And it's just really, it's really important that this isn't crisis. I mean, I say this to them every single time is, if you meet everything with crisis, it becomes a crisis. And this really isn't. This is, people within our communities who are being identified as, perhaps just needing some outreach, housing. It's, in my community, our librarian in Essex Junction uses this for people that come into the library and are in need, or are in having a mental health crisis, but not a crisis, not a desperate crisis. Or, I mean, Representative Houghton had a woman next to the flower shop who was sleeping out by the flower shop and was cold and needed some help. And she called, and they come out and they meet people where they are. And it's an invaluable,
Been very effective. So
it's been
Representative Bishop was in here yesterday,
Yes.
and every single legislator in Chittenden County, party neutral.
Yes,
Absolutely.
absolutely.
Keep this. I actually have heard from former legislators, recent former legislators saying, please do not.
I
Get rid of
received
this. So this
I received communication from every single town in Chittenden County, all legislators.
Yes, mayors. We've received
Yes,
a lot of letters.
Please.
Yes, and our police
Yes,
department.
right.
I meet personally with the police chief of Essex every single year, and the one thing he thanks me for is this program.
Yeah.
That
Great.
it is invaluable.
Thank you.
And number 7, of course, this is where I cry every year, but
So this is in, when we heard from the delegation, they put in for money for Bridges to Health. And I talked to Rep. Houghton, who is your house, she
Yes.
talked about this. She's checking into whether the delegation is going to be able to cover that.
Okay, I had not heard that.
Mhm.
So thinking,
We learned it when they came to us on Monday, Tuesday.
that means I'm not gonna cry.
I'm
I'm sorry, I love Bridges to Health. I think
This
they're,
this is also,
yes,
okay, Department of Health. My understanding from the Department of Health, this is a pass through to
Yes.
UVM to the Extension Service.
I think
It
it's,
handles it now.
yes,
And from what I understand, now it says here it's going to transition to the Vermont Free and Referral.
yes. They are leaving UVM. They have always been part of UVM Extension. And they have found a new home with the free and referral clinics. Although they are separate, they are completely separate programs, but they're,
Yeah, I'm familiar with the
Yeah,
program.
yeah.
Now, there is a couple of carry forwards in that go to December 26th. Is this $500,000 supposed to be just for the rest of 27?
it's for the rest of 27, yes. So it is not a full year. It is enough after their carry forward. Okay.
Thank you.
The Office of the Healthcare Advocate. This is not new positions. This is just simply, he's been level funded for, I'd say I'm sorry, the office has been level funded for a few years. And this is, essentially increase for their employees. I'll put in a little, I'll put in a plug in. There are many things that we have all worked on over many years, and those have come to us from the Office of the Healthcare Advocate. And the common theme that runs through all the proposals that have come forward. I mean, you can think about things like Medicare Savings Plan program. IHIP came from the Office of the Healthcare Advocate. They have increasing responsibilities that we statutorily put on them. They are a party to everything that the Green Mountain Care Board does and much of what AHS is doing. And the common theme, though, that I would say that runs through everything of the Office of the Healthcare Advocate is you can look and you can say, this is good for Vermonters. And this represents Vermonters and affordability and
Okay,
that's what their office says. That's it.
Because you have, we do need a break, so.
It's okay.
You have a quick question?
No.
Okay, if there's a lot we can talk about offline, that would
Team
be.
two, do you want to talk about team two here real quick? Because you're
Yes.
much more well-versed in it.
Team two is a training for first responders, law enforcement and such that has been around for about 12 years, was developed in partnership with some first responders and the Department of Mental Health. The Department of Mental Health now has identified that they can bring this service to first responders in-house. So they have a crisis team in-house that they're gonna have deliver this training to folks who request it.
And then finally, number 10 was VSAC, which is the loan repayment for allied health professionals. And again, this is in here. There is talks around whether or not the RHTP.
Right.
And so I'm just going to leave it at that.
Okay, and you have some language?
We have some language. Oh, there's another line item in there around Vermont 211.
Yep.
So within the governor's recommend, it was a reduction to 211. And they also are doing a program that is a closed loop referral with UVM network.
No.
Where essentially providers are now able to sort of refer to 211, who then can refer a person to services that comes back to the provider to ensure that it's a closed loop.
That somebody followed us, actually did, the use of the referral.
We are recommending funding of this, and there is the HIT fund, a special fund that does have a surplus in it, and this absolutely would qualify as something that the HIT fund, or we believe that the HIT fund would.
There's an allowable use. of
Yes,
it.
an allowable use.
Yeah, is this a one-time,
This is a one-time.
is this 332, that is for the 211 services generally?
So we did not make recommendations around the cut of the base of 211, which is in the governor's recommend, but we did recommend their ask for developing this closed loop referral, and we're suggesting using the HIT fund for that, and that's a one-time.
Okay, but would this be in addition to how they're funded through DCF, or is this a way of preserving 211 services?
We are not recommending. It preserves it. I believe that the response from, and is it DCF? You have to, we actually don't have them in our committee, so there was a lot of, I think, human services. We made no made no recommendation to not concur,
Address whether the 20%.
yes, not concur with the governor's recommend.
But this funds
This fund's a separate,
efficiencies
Specific,
that are
yes.
really necessary for communicating and care coordination of providers.
And you found the fund. The next one?
there's an elimination of a sunset, and that is, through AHAC because they have some carry forward and they have 11 students that they would like to award it to. So it's just language around removing a sunset on it.
Does that keep AHET?
No, it allows them to spend the money they have left.
Okay. So regardless of what we decide on the other page, this is separate. Okay. Did you have a question?
I was real quick, we can keep moving ahead.
Huh?
We can keep moving ahead.
Okay.
Yeah.
All right, and then C?
So again, we have language in here that, our intent that Department of Vermont have health access, figure out how to implement coding changes that enable a state 90-10 match on federal funds for family planning services. We did this last year in the budget. They came back in the BAA and said it wasn't implementable. This 90-10 match has been around for, I think, 42 years. We're recommending that they figure it out. So we're gonna keep putting the language in there. This is a 90-10 match that we have been foregoing since the inception of this.
AHS is not doing this.
Shiva is
Eva is
doing
not
this.
doing this.
Yes. It's how claims are coded, how these claims would be identified, and we're asking them to please, and at least
Report back to.
they have to report back and not report back that they couldn't do it, but report back on the steps they have taken to actually do it. So we're recommending that. And then there is we had a bill, H 585, which allows AHS to seek a waiver for reinsert, a 1332 waiver of reinsurance through CMS. And we have taken the language out of that 585 and put it here in the budget. And this just tells them that they can seek a waiver.
Okay.
Right? And that's about it. And thank you for.
Thank you for all the work you've done. You've had to make a lot of hard decisions too, and you're one policy committee. Glad you guys are on this, because this is very complex stuff, so it's really, thank you to the committee.
I'm glad you're the one looking at that column and not us.
It's gonna be a tough year, and you've acknowledged that. We appreciate that. Thank you so much. We have, people will come back to you with questions. I think we have some more information we're gonna get from you, and here, so thank you so much.
Thank you.
Appreciate it. Committee, we are gonna take a break. If everybody that's coming in for 10